whether our community, how prepared our community might be for implementation of the Affordable Care Act, which is right around the corner. So with that, we'd like to turn it over to our chair of our county commission, Leslie Campione.
Thank you very much. And on behalf of the Lake County Board of County Commissioners, I want to welcome you and thank you for your participation in this very important discussion today. I will speak later on to the role of the Board of County Commissioners and our specific interest in assuring that Lake County residents have access to affordable, quality health care in a timely manner. As I prepared for this forum, it became apparent to me that while each organization that is represented in this room today has its own mission and purpose, we all benefit from the success of one another. And to that end, we have a unique opportunity to realize our own goals by recognizing the relationship we each have with one another and functioning as partners. So with that being said, let's get to work.
Thank you.
Welcome. For those of you that don't know me, I'm Donna Gregory, and I'm the administrator of the Florida Department of Health in Lake County, previously known as Lake County Health Department. And I too want to welcome you, but we will begin with our strategic plan from our CHIP. When Lake County Community Health Improvement Plan was developed in the fall of 2012, the Patient Protection and Affordable Care Act future status and form was uncertain, and it was not prominently addressed in our final CHIP. Now, after the elections and judicial review, we now know what form of the ACA will be slated for full implementation on January 2014. Although there are questions and issues about aspects of the ACA as well as its funding, there is a looming issue on the horizon. Are communities ready for the implementation of ACA? A special concern is whether there will be sufficient physician and other health professional staffing and programs in place should there be a significant increase in demand for primary care and other healthcare services as a result of the ACA implementation. Health professional staffing capacity was already identified as one of the major issues impacting our county. There isn't enough capacity to adequately serve current health access demand. This strategic forum will help us factor in the ACA's potential impact on our Lake County CHIP. The issue will be addressed from the unique perspective of key stakeholders, and each will share what major health professional capacity challenges and opportunities are presented by the implementation of the ACA in 2014. How the organization is addressing these challenges or opportunities, and what assistance from stakeholders, the community, the state, or federal sources will be necessary to meet the challenges or opportunities presented. During a subsequent question and answer session, each of these questions will be developed. In the closing session, common themes will be summarized and community options to ACA implementation, challenges and opportunities will be discussed and recommendations made for consideration in the Lake CHIP going forward. Thank you for joining us today to address this important issue. At this time, I would like to introduce Wally Plosky, Wally is filling in for the Well Florida. Jeff Feller was going to assist us and had something come up in another area of the state and has asked Wally to take the lead as the facilitator. So with that said, Wally has been promoting, expanding, or facilitating health access in communities throughout the country for over 40 years. His community development efforts have been endorsed and supported by governmental entities at the federal, state, and local levels, by regional and local healthcare systems, by foundations, and most importantly, by individual communities in both rural and urban settings. For the past 20 years, Wally has focused on facilitation of expanded access to quality, cost-effective, affordable, and comprehensive primary care and integrated safety net systems of care. This has included developing, resourcing, implementing federally qualified health centers and community initiatives to reduce avoidable emergency room use and reduce avoidable hospital readmissions. Wally has retired from the Florida Department of Health in Lake County, but is continuing a consulting practice around access to care and currently is working with Florida State University's colleagues of medicine and nursing and their 3 communities and 3 other communities in Florida. So at this time, welcome Wally.
Thank you, Donna. And again, as a retired person in Florida, I should be out there in the sun, but you know, I wish I could fill in Jeff Feller's footsteps, because those of you who knew Jeff, at one time Jeff was a little bit larger than he is now, and I have not quite been able to lose that same amount of weight. So my goal is to be just like Jeff Feller when I grow up. But anyway, because we're going to be covering so much information, and we are not going to take a lot of time discussing the Affordable Care Act, some of the key issues, but what we've done instead is we have provided the PowerPoint discussions that are in your individual packets, and this particular presentation does go into a number of key issues as far as the implementation of the Affordable Care Act. We may allude to them, but from the perspective of the presenters, I think it's more important to know what our community is going to do about the Affordable Care Act. But please feel free, from the standpoint of how we're going to structure this, because we have such a short period of time, we're going to ask each presenter to make their presentations, and then there will be a short question and answer from among the other panelists. So for instance, when the hospitals make their presentation, if there's someone else in the panel who might want to ask a question about that, we're going to allow them an opportunity to do that. On your table, we have cards. If you have questions that you would like to have addressed, please fill out the question on the card. And at the end, depending on how much time we have available, we like to get to as many of those questions as possible. But just to tell you, typically just to talk about the ACA takes about 4 to 6 hours, the meetings that I've had to go to, and it wouldn't be fair to you, and it wouldn't be fair to everyone else. But we will try to get back to you. Please write down your questions. And those that we can't answer, if they seem to be a common question from a number of sources, we'll try to get back to you, come up with an answer and get it back to you either by email or by posting it on one of our sites. Just a couple of key things I'm supposed to say is there are bathrooms that way and there are bathrooms that way. Not this way or that way, but either place. And please feel free, since we aren't going to have any breaks, to get up and go whenever you think you need to just take a stroll. So with that, I would like to just give just a tiny overview. The Affordable Care Act, most of us think about the Affordable Care Act, what we hear in Tallahassee about whether there will be a state expansion of Medicaid to implement the Affordable Care Act. Medicaid is only about 1/3 of the Affordable Care Act. The Affordable Care Act provides a tax credit for people up to 400% of the poverty level. 400% of the poverty level is $94,000 for a family of 4. there are a lot of people that are going to be eligible to purchase health insurance through health insurance marketplaces that are going to go into effect October 1st of this year. There are insurance companies right now putting together qualified health plans, and for persons who are between 133% of the poverty level, which is a family of 4, about 32,000, and people up to 250% of the poverty level, about $53,000 for an annual income, they'll be eligible to buy health insurance on these marketplace exchanges, and they will have the cost of that insurance subsidized by tax credits. There'll be kind of a sliding fee opportunity. And for persons whose income is between 250% or the 53,000 range and the 400% range, they will be allowed to have a tax credit from the standpoint of purchasing plans. And we're talking about a plan that's called a qualified health plan, and everything I'm describing in here is in the PowerPoints. So please don't feel that you have to write down a lot of stuff. It's all there, but I'm just kind of giving you a little bit of an overview. So this thing is not just Medicaid, it's really a lot of people in the community. In our community, that could be up to 55,000 people who may be eligible for health insurance coverage, whether it's Medicaid or whether it be insurance coverage. So it's a big thing, and so we're really, really thankful that these panelists took the opportunity to or made the commitment to really help us with understanding where we go from here. So with that, I would like to, our first presenter actually was going to be Carol. Steve, would you like to? We're going to try to pull up. Carol there's a physician who is going to be joining Carol, and he actually is seeing patients early this morning. He's going to try to break away and still get here before the presentation is over. So with that, John Cherry was also going to be joining us. And John was fighting the battle. Those of you who may know, John Cherry is the Chief Executive Officer of Livestream Behavioral Health Services. And the mental health, behavioral health community has been really challenged in Tallahassee. He's been living there, I think, just about 24 hours a day. But he will be joining us as soon as he can break away from a legislative commitment. So with that, I think we'll say next up, Ken, would you like to kind of pop on up and take over?
Trying to think of an excuse not to go next, so
Ken, forward and back, and we'll get your presentation. It's good. I'll get my paper out of here. I'll get an intro here. It's all good. Bear with us.
good morning.
Good morning. Good morning.
Are you enjoying the heat again? No? Isn't that what we come to Florida for, is to enjoy the heat? When I think about answering the question, what do we need to be doing to get ready for the Affordable Care Act, we've tried to put together some information that might be helpful in answering that question. But I want to start out by telling you that the president of Adventist Health System, which is the parent company of Florida Hospital Waterman, when this was being discussed early on, encouraged us not to focus on the politics of healthcare reform, but on what the eventuality would require of us as a provider of healthcare. He said, I don't want to hear you guys out there getting involved with the politics, trying to influence it one way or the other. He says, I want you focused on whatever the country decides, we need to be ready for it. And so he said, what you as a hospital administrator need to be focused on is how do you improve quality and how do you lower the cost of providing care. Now, as community citizens and residents in the community, we are actively involved in the political process. But he didn't want us focusing all of our time on trying to influence the law and miss out on the opportunity of what was going to happen when whatever evolved actually came about. So we're going to talk a little bit the mission of Florida Hospital Waterman, because we are a faith-based company. The mission is a spiritual mission. We're sponsored by the Seventh-day Adventist Church, but our purpose is not to convert people to a particular brand of religion. Our purpose is to honor God with the care that we provide. And when you think about the business case for healthcare, we hired a consultant back in August of 2012, a couple of PhD professors in economics, and asked them to give us a perspective of the economic impact of Florida Hospital Waterman on Lake County. And specifically, we wanted to answer the question, what if the hospital were to go away? What impact would that have on the community? So the impact of the hospital system and the impact of investments in the community. So the contributions and benefits will be broken out into these various categories. And that middle one there, from taxes paid, you might wonder, well, I thought you were tax exempt as an organization, and yet there are a substantial amount of taxes that are paid by the hospital. The multiple factors or the multipliers that are involved deal with the employment multiplier, the income multiplier, and the output multiplier. You have those in your PowerPoint, so we're not going to try and break those down, but these were what was utilized to help determine the economic impact of the institution. There's a couple of other multipliers, the construction multiplier and then the employee involvement factor for every Florida Hospital Waterman employee, and this would also apply to Leesburg or any other healthcare institution. These multipliers apply across the board, so even though I am speaking from what I know, they do apply to other healthcare institutions across the community. So based on all of that introduction, when you look at the financial impact, as a healthcare provider, the impact to the community is worth about $125.1 million. As an employer, $127.8 million. From capital investments, another $9.5 million. The unreimbursed treatment of those in our community is worth $22.7 million. Taxes paid, $2.3 million. Through the employee involvement, $1.5 million. Via non-billed and in-kind services that we provide, another $1 million. And then from our faith-based care, $0.6 million, which means that Florida Hospital Waterman, as an economic engine, or as the financial impact as an institution, is worth about $290.5 million to Lake County. The economy of Lake County is calculated to be about $3.4 billion, so Florida Hospital Waterman represents about 8.4% of the total economy. If you multiply what you've now known or now know about Florida Hospital Waterman, and you drive the impact to Leesburg Regional Medical Center or the Alliance, the impact of healthcare institutions to the community is a substantial driver of the economy, and we want that recognized. We want you as a community to recognize the value. We're not there just to take care of sick people. We're there as an economic driver for our communities, and we take that responsibility very seriously. The economics of healthcare, many of you may have seen this. Going to try and drive a little bit of why we think reform is needed, and recognize, as a conservative Republican myself, I'm conflicted when we talk about some of the things that I need to talk about for the benefit of the community, and I know that up front, and I just want to divulge to you that I, as a healthcare administrator, may sometimes be in conflict with some of the very values that, as a conservative Republican, I may struggle with. So recognize that I'm conflicted. In fact, my wife will probably tell you I'm conflicted. Don't tell her I said that. So we're going to look at this graph here and try and understand some of the economics that are involved in healthcare. Medicare, as a block of patients that we care for, is, and on the graph you'll notice that it, on the horizontal axis, represents about 62, 67, actually it's about 62% of our portfolio of patient population. And on the vertical axis, you'll find what percent of what it costs to provide that care is actually reimbursed by the Medicare system. So if the pink represents 100% of what it costs to provide care, Medicare reimburses about 93, 94, maybe 95% of what it actually costs to provide that care. Medicaid as an insurer represents another roughly 11 or 12% of our patient population, and the reimbursement that we receive from Medicaid covers less than 80% of what it costs to provide care to those in our community that have that kind of insurance. The category of self-pay, those people for which they have no insurance coverage, represents about 9% of our population, 7 to 9%, and they reimburse the hospital about 10% of what it costs to provide that health care. The unreimbursed cost, or that's what's left over in the pink, is what the shortfall for all of this group of patients that we're talking about, which right now is just under 80% of our total patient care. The shortfall of that has to be made up somewhere. And it's basically left to those with commercial insurance who provide, frankly, the shortfall. And when you think about it, that amount over what it costs to provide that care, that they're having to make up, that 20% of the population or 22% of the population that have some kind of commercial insurance, that really is a hidden tax to the rest of society borne by those who have commercial insurance, making up for the shortfall on the governmental pay. Now, that's the way the system is today, and the reality is frankly, that's not sustainable long term. As more and more people fall into the governmental pay category, there's going to be fewer and fewer people that have commercial insurance, therefore making the case that what we have today, we can't continue to believe doesn't need fixed. It's broken. It needs to be fixed. And what we're dealing with now is how do we actually fund health care. And that's why the push by our CEO, Don Jernigan, focus on higher quality and lower cost, because that's what our society is going to demand of health care in the future. Some of you have seen this before, and I'll apologize if it's a duplication. When we look at Florida Hospital Waterman patient mix, you'll notice on the left-hand side that and we'll start on the left-hand side of the legend there. The uninsured make up about 8%. They're in red. Medicaid represents 12%. That's in the yellow. Medicare, 62% of our population, leaving 18% to the commercial side. If we were to compare Florida Hospital Waterman's, and I would imagine, by the way, that that mix of patients is very comparable to our colleagues in Leesburg as well, because we serve virtually the same population. In Orange County, and because we're a part of the system, Florida Hospital has been able to share this information with us. If you take a look at the uninsured in Orange County, that's 7% of their population, comparable to our 8%, so that compares comparably. Medicaid represents about 9% for them, 12% for us. But the big difference is really in the two categories, Medicare and commercial insurance. If you were a hospital in Orange County and you were taking care of the general population, that represents about 30% of the care that is needed, leaving 54% in the commercial insurance category. That candidly allows for the cost shifting that you saw in the previous slide, where we saw the losses on the governmental pay being borne by a very small percent of the population. In Orange County, or for those communities, whether it's Orange County or you name the community that doesn't have the proliferation of Medicare patients, that cost shifting is a little easier to do, which which really brings us to the whole need for community support for the burden of indigent care within a community. And I know that's been a topic of discussion that Vance, I know you've been a part of for a long time, and it's appropriate that we as a community frankly try and answer the question, do I, as a member of this community, have a responsibility to participate in the provision of care for those who are disadvantaged among us? As a hospital administrator, I would tell you that I would hope that as a community you would recognize the importance of your contribution as a community to provide or to help provide care to those who are disadvantaged among us. Because candidly, but for the grace of God, there go I could be one of those people that's showing up in the emergency room because I've lost my job or I don't have the means with which to pay for the health care that I need. So therefore, it would be my request that as a community, you recognize the importance of some kind of support to those who are on the front line of providing care in the community. Some have asked, well, you know, hospitals are very inefficient, and you don't deserve the support from the community. Well, I want to answer that question by telling you that, and this was a study that was done in 2010. It's the most recent information that we had available at the time we were presenting this or preparing this. But the focus is from the American Hospital Directory, and it's looking at the case mix adjusted cost per case. Case mix adjusted takes into consideration the severity of illness that a patient might have. So if you're really, really sick, you can't compare with those people that come in with a sore throat. So there's a way, through the way that they analyze the diagnoses and the care that's provided, to be able to adjust that out by case mix so that it levels that. So from a case mix adjusted cost per case, if you're in the top quartile, your case mix adjusted cost per case is about just over $6,000. If you're in the top decile, that's the top 10% of efficient hospitals across the country, that number is just under $5,000 per case. At Florida Hospital Waterman, our figure was $4,954. I'm pretty proud of the fact that Florida Hospital Waterman is an efficient provider of health care. And this data helps to analyze or helps to answer that question, are you an efficient provider of care? And yes, we are. We've also tried hard to find ways to communicate, in addition to what is the economic impact of the hospital, what is the benefit, the community benefit that we as an institution provide to the community. In 2011, that community benefit, if you look at the bottom line, oh, I have just done a boo-boo. Man, I hate it when I do that. There is not a pointer on that I'm going to do that again. Okay, go to the next one, Wally, and then we'll do a shift F5, and that gets us right where we need to go. That's 12. Can you do a, get it back on no, yeah, and then just shift F5 gets it to the power, to the screen.
I'm tired, I don't remember those.
You're good, you're good, you're all good. So in 2011, put that up down so that you don't do that again, Ken. Looking at total community benefit for 2011, that figure's about $17.6 million. If you add to that the amount of money that was spent for capital improvements, which is also a community benefit, that total, if you add those two together, looking at about 20, what is that, 23, $24 million? Okay. In 2012, the community benefit, and do the comparison, when you look at a benefit to the underprivileged, the $12.6 million of benefit to the underprivileged, offset by the benefit of the indigent care tax of $4.1 million. Add to that then the community benefit where the benefit to the underprivileged increased and the amount of tax proceeds available dropped. But you'll notice that the benefit to the elderly, those on Medicare, increased to where that community benefit in 2012 totaled $25.3 million, Add to that the fact that we spent $16 million in capital improvements to the healthcare infrastructure for this community, and you'll see that there was a substantial increase in community benefit. So to answer the question, you know, we're tax exempt, so therefore we should be able, with the benefit that we derive as a tax exempt organization, we should be able to provide all the care that would be needed in a community because we get that tax exemption. And yet I'm here to tell you that if you calculate what we would have paid in taxes had we been a taxable organization, would have been about $10.9 million. Okay? That's how much we would have paid in taxes. Add to that roughly $4.1 million in tax proceeds that we derive. We're looking at about a benefit to the hospital of about $15 million. And yet from a community benefit, you're looking at a $24.4 million community benefit in 2011. Climbing to 41.4. So what I'm hoping to share with you, we're not telling you that you need to do more to help us. We just want you to recognize that with the support that we get, both in tax-exempt status and the tax proceeds that we receive, we're still providing more than that in value to the community. And we wanted to make sure that you understood that because we want to be good partners in the community. We want you to see us as allies, as together we focus on meeting the needs of the community. And I'm going to wrap up my comments with just a brief comment about what I see the future of health care, where we're going. There is not enough money in this country to pay for health care the way we've been doing it all along. The proliferation of diabetes, the proliferation of diseases that candidly are brought on because of health choices that we make as a society. If we don't bend the demand curve for healthcare services, we're going to go under as an industry, and as a society, we're going to continue to be complaining about the cost to provide intervention healthcare after the fact. It's been estimated that approximately 80% of the chronic diseases that we care for in these United States are chronic diseases because of choices that we have made. So if, as a healthcare industry, we're not focused on improving the health status of the community that we serve, we're not going to make it. The impact of individual accountability and the impact of choices that I make as an individual that are then borne by the rest of society because of the way that we have set up the healthcare delivery system, fundamentally that has to change to the point that if we're not improving health status, we won't be able to afford what's coming in the delivery of health care. We have created the Creation Health Program. It's an acronym that takes the 8 principles of health and tries to assign a process by which we start to educate our community. And by the way, there is no reimbursement for this. No health plan, no the Medicare program, the Medicaid program. Nobody is out there saying if you improve health status, you can make money for that or we'll pay you. Right now, the only way a hospital or a doctor gets paid for any of this is when they deliver care to somebody who is injured or ill. And we've got to change that so that the emphasis is on how do we improve health status. And that's a focus that we're focusing on right now because we think that's the only way we're going to be able to bend the demand curve and live within what we can afford as a country, what healthcare is going to cost. Thank you very much.
Thank you, Ken. And by the way, as a facilitator, since I'm kind of new at this, one of the most important things that you have to do is to make sure that the audience knows who it is that is basically making the presentation, what that individual's credentials are. So at this time, we're going to kind of change the order as we've changed some of the other agenda. And let me kind of fill in a little bit of background on Ken. Ken graduated in 1976 with a degree in business administration. After graduation, he worked 3 years as a staff accountant at Castle Memorial Medical Center on the island of Oahu in Hawaii. From 1979 to 1981, he was a patient's business manager at Scott Memorial Hospital in Lawrenceburg, Tennessee. Then he went to Gordon Hospital in Calhoun, Georgia, where he started as the patient business manager, then controller, and finally as vice president and chief financial officer. From 1985 to 1991, he was the vice president, chief operating officer at Park Ridge Hospital in Fletcher, North Carolina. In 1991, he became CEO at Jellicoe Community Hospital in Jellicoe, Tennessee, a 54-bed rural community in the Appalachian Mountains. Since April of 1997, Ken has been the president of Florida Hospital Watermen, located in Tiberias. Ken and his wife Sharon have 2 sons, 2 grandchildren. They have been married for 39 years. His other interests include family, church, mission trips, maintaining Spanish as a second language, music, and restoring antique cars. So Ken, you have been just a real treasure to the community, and we thank you for participating in this process.
Thank you.
For the next presentation, if we could, since the doctor that was going to be joining us is not here yet, Commissioner
again?
Nope, I think in fairness, Central Florida Health Alliance would like to come up there. And I would assume that much of what you shared is basically the same kinds of things that Central Florida faces, and I think there is kind of an underappreciation of the economic engines that our hospitals are, and the fact that they're real assets to our community. For the next presenter, and I'm going to try to do things ambidextrously here. I'm going to switch over. I think if I can do this, Sherry can help me. I just wanted to. This time I'd like to introduce our chair of our county commission, Leslie Campione. She represents District 4. Leslie Shamrock Campione was born in Orlando, Florida, and moved to Lake County with her family in 1971. She graduated from Eustis High School in 1982, and in 1986 received her Bachelor of Arts degree with academic honors from Permanent University in Greenville, South Carolina, a tremendously beautiful town. I've had the privilege of performing there a couple times. It's just a gorgeous town. In 1989, Leslie graduated with honors from the University of Florida College of Law, where she was a member of the moot court team. After working in Atlanta, Georgia, Leslie returned to Lake County in 1991. Since 1993, Leslie has owned her own law practice, focusing in the areas of local government law, environmental law, real property, business, and land use law. Leslie served as a city attorney for the town of Lady Lake, the town of Monteverde, and the city of Umatilla. Leslie has 2 children, 3 stepchildren, and is married to Dr. Jack Castle. Leslie has served the community in many capacities, including junior achievement teacher, YMCA coach, Eustis Service League former president, leadership with Lake County, and volunteer teacher with the Justice Teaching. The Justice Teaching Program was established by Chief Justice Lewis of the Florida Supreme Court to utilize volunteer lawyers and judges to instruct elementary, middle, and high school students about the United States Constitution, the Florida Constitution, and the judicial process through interactive lessons and case studies. Leslie is a strong proponent of economic development and free market principles and is committed to fostering a climate of positive economic activity, small business ownership, and job creation through good planning, balanced policies that protect our valuable natural resources and the unique quality of the life we enjoy in Lake County. Please welcome again Commissioner Leslie Campione.
Well, thank you for that introduction, and as you probably noted, I'm not an expert in healthcare, and that is not necessarily one of those areas that until I became a county commissioner did I start really focusing on the connection between health care, access, quality of health care, and our role as county commissioners in protecting and promoting our quality of life in Lake County and fulfilling our basic responsibilities as county government. So what I'd like to do is give you an overview of where county government comes into this equation. Let's see, here's my clicker. So as I mentioned, the general concept of health, safety, and welfare is the basis upon which local governments have authority to engage in activities associated with health care. However, there's no specific statutory requirement that imposes upon county government the participation in health care delivery. But there are specific statutes that require that a level of funding be provided to various programs, and I'll get into that in just a minute. Of course, quality of life issues, what I have found in serving as a county commissioner is that everyone has a different view on what quality of life means to them, and I think that in Lake County you'll find a lot of people believe that just being left alone is a big part of their quality of life in Lake County. Other folks want to be able to go to the library, check out a book, take their kids to ballparks and so forth, but I think that we can all agree that having access to health care is important to everyone, and especially when it comes to getting emergency services and knowing that in the event of emergency you will be taken care of. And that's a big part of where Lake County comes into this. Economic development, job creation, and our tax base, we all know there's a correlation there. And community that has a higher tax base, has better unemployment rates and so forth, you're going to see better outcomes in your health care, you're going to see better accessibility, and so forth. So we know there's that direct correlation. As far as our role as county commissioners, I state on this slide that we're a facilitator, not a healthcare provider. But in actuality, we do have a part of that, that equation as being a healthcare provider, and I've got two people here on behalf of Lake EMS, and that's a very important part of what we do from being a provider. Our board sits on the board of directors for the Lake EMS. And in addition to that, our Lake County Fire Department, I wish I had the exact percentage, but I can say that it's the majority of our firefighters in Lake County are paramedics and ALS trained. Our goal is for all firefighters to be so because they are an important part of getting to a scene as quickly as possible, and then Lake EMS and our firefighters having exactly the same medical protocols and working together and getting patients transported in a timely manner. Funding sources, property taxes, that's probably the biggest part of our funding sources. Sales taxes that come back to Lake County, some grants, and these all go into our general fund. Interestingly, the county budget is, almost $400 million, but out of that, a lot of it is, areas where, for example, transportation needs, those are funded from gas taxes, so that kind of sits on its own. Solid waste collection primarily is funded through solid waste assessment, so it sits on its own. When you actually get to the part of the budget that we control, we're looking at about $120 million, and of that, about half of that goes to law enforcement. And the Sheriff's Department, running the jail and so forth. So then you get to the part that the County Commission controls, and we're looking at only, roughly $32 million. So when I show you some of the mandated funding that we have, it's coming out of that part. So it represents a pretty significant part of our general fund budget. So we'll look at mandated programs. Lake County government is required to provide for Medicaid, hospital, nursing home billing, and that essentially is nursing home care for Medicaid residents of Lake County, and day 10 through day 45 of hospital care for residents of Lake County that are on Medicaid. The Health Care Responsibility Act requires us to compensate providers outside of Lake County that provide care to our Medicaid patients. So if someone is transported to downtown Orlando, we're going to get a bill for that service if they're a Medicaid patient. Of course, cremation and burial assistance for the indigent, the County Public Health Unit contract, life stream behavioral contract, and that's actually based on a state formula as far as what we're required to pay. Inmate medical invoice administration. You can see this is a pretty significant amount. These are the inmates in our county jail that are either taken to the doctor's office or they're taken to the hospital. Transportation disadvantage program. Again, you can see this is a pretty significant part of our budget, and this is for Medicaid patients, those that qualify as disadvantaged. Under a variety of programs, we provide transportation to the doctor's office, to medical health providers, and also for nutritional needs to the grocery store. And then we fund a portion of the medical examiner's office. Now, discretionary health care programs. We Care Contract Administration, which is a volunteer doctor's program that provides surgery to the indigent. New Vision for Independence, Lake Cares, Inc., Society of St. Vincent Paul, Easter Seals, Haven of Lake and Sumter Counties, the Children's Advocacy Center, the preventative dental care expansion through the Health Department. We also assist with leases and property management for the Health Department, and the operation and funding of Lake EMS through the tax subsidy that goes to offset the cost of providing to the uninsured, to the indigent, and so forth. So most of you are probably familiar with most of those discretionary programs. As far as economic development, job creation, and tax base, we talked about the correlation between healthcare access and local economic conditions. We are committed as a county commission to attracting and retaining businesses in Lake County, and we take a very active role in that. We work directly with companies in Lake County, getting to know them, understand their businesses, and helping them when it comes to connecting them with our education providers and meeting their workforce needs. We know in Lake County that we have companies that would like to expand, that would like to grow their businesses, but there are shortfalls when it comes to the level of training that we're able to provide in Lake County. So that's an area where, in partnership with Lake Tech, the school district, Lake County, Board of County Commissioners, and our business community, we are trying to address those workforce needs. Workforce development, this goes hand in hand with our discussion today. Obviously we need a healthy workforce, we need a dedicated workforce, and we need to meet the training and have that available to residents. Tax-based distribution, we know in Lake County that we have kind of an unequal balance when it comes to our tax-based distribution. We have a lot of residential on our tax rolls, and not nearly enough of commercial and industrial land uses in Lake County. If you look at our distribution and you compare it to Orange County, you'll see a very different mix. So again, that's something that as county commissioners we can focus on, trying to get that balance, trying to get companies here, get job opportunities here, so that then our tax rolls are more balanced, which means it's a much better distribution when it comes to funding the services that we need to fund. We talked a little bit about quality of life and how it has different meanings, but I think that everyone has certain minimum expectations about accessibility to health care. Setting priorities as a community, when it comes to our discretionary funding, I think that everyone is in agreement that children, the disabled, the elderly, is kind of, we can get in arguments about politics and ideology and so forth, but I think as a general rule, most Americans feel that there are basic needs we need to be helping to take care of. Indigent care, again, that's somewhat of a continuum. There are some that feel you should go much further in that regard from a local standpoint, and others that see the possibility of expanding government further, creating dependency upon government and all of that. Emergency care, minimum expectations. I think we all want to know that if we have an emergency, they will get to us quickly, we'll have good response times, we'll get to a hospital, and we'll be able to be seen in a timely manner. So this is an expectation that really goes hand in hand, too, with us on the EMS side and the hospitals on the ER side. Availability of hospital beds, nursing facilities, and rehabilitation. Just recently I had a good friend whose mother could not find access into a rehabilitation facility. Just wasn't available. And had to wait several days, really needed to be there, but eventually something opened up. But in considering the demographics of our population here in Lake County, that's a critical part, I believe, of the quality of life. Of course, access to primary care doctors and specialists, being able to get diagnostic services and access to surgery and so forth. The optimal situation, of course, is that it's affordable, it's accessible, and it's high quality. And that's where we all want to be. Getting there is where we may get into disagreements. Of course, the mandated funding side of it, as county government, we have to pay for these things. But as elected officials, and I think I can speak on behalf of our entire board, we feel a very strong commitment to our constituents to be able to assure them that while we were required to provide these dollars to a particular program, we can tell you that they're being used effectively and efficiently. And that's where partnership is so critical, that we're working closely with our partners and that we can make those claims and those representations, that their dollars are being used wisely. Discretionary funding and community participation. With all of our grants that we provide for children's services and social services, we have a very strict process by which the applications are made, they're reviewed, and so forth, so that we can know that these dollars are being used wisely. Setting priorities, of course, you can't do everything, and so you try to find those areas where you feel you can have the greatest impact. And reaching consensus, ideology and politics. I would say, as a general rule, our board feels that volunteerism, charities, churches, any organizations that are willing to step up and take an active role in providing care in the community, we very much support that as a method of getting services to those who need the services the most. Personal responsibility, preventative care. I really enjoyed hearing Ken's discussion about the role of prevention and wellness, and that there's a huge debate there about how far do you go getting people into doctor's offices that are already well when you may be taking the slot of somebody that really needs to be there, and how do you change people's behavior? We know in New York City the mayor has decided you can't drink sodas from a certain size cup. How far are we going to go to try to change people's behavior? And that brings us full circle with, as a community, what is our ideology, what is our philosophy, and how we make decisions about the programs we're going to be involved in and we're going to fund. I think that those issues do come into play. I think education is key, and personal responsibility. At that point, we hope people do the right thing. But size and scope of government, and again, dependency concerns. Concerns that if we create a program, then people will become reliant upon that as opposed to taking responsibility themselves. I did want to close by reiterating something I said earlier, and that is that if we do our job well as a county commission, and the organizations represented here in our community and the healthcare community do their job to fulfill their own mission, we all benefit. And so we have this connection, and we can help each other in this ultimate mission, which is to provide affordable health care and make it accessible. But I think we have to look at it as a joint effort, although we each have our specific role. But we have to look at that bigger picture. And if each of us succeed, I think it helps all of us succeed. So with that, hopefully, oh good, it looks like the doctor is in the house. Okay, well thank you very much.
Thank you. And with that segue, we've really done quite well. Let me introduce first Carol Millwater, and she can then introduce her guest who will be giving the presentation on behalf of the Medical Society, I believe. Carol Millwater wears two hats as Executive Director of the Lake Sumter Medical Society and as Executive Director of We Care of Lake County since 2008 and 2009, respectively. In a role with the Medical Society, Carol advocates for the rights of physicians in medical practice. She coordinates member meetings and educational events. She provides support, guidance for medical practices. She publishes quarterly magazine, weekly newsletters, and this is my favorite, oversees and manages an annual trade show and annual golf tournament. In her role with We Care, she coordinates volunteer services for patients, recruits volunteer physicians, maintains relationship with funders, and seeks community recognition and donations. Carol has over 29 years of successful experience in organizational management, strategic planning, fundraising, and executive leadership in the nonprofit sector, including faith-based entities, hospitals, and child and family initiatives. Carol has been very active in the community she's lived, serving on boards and advocacy groups, including the board of the Gateway Community Health Network, an FQHC lookalike, Lake Sumter State College advisory committees, the Orlando Medical News, and numerous child and family outreach programs in Louisiana, where they have the good food. So with that, Carol, come on up and introduce your guests.
Well, actually, I thought I would kind of lead into this a little bit before I introduce Dr. Boardman. The Medical Society, actually, I really wish I were here to talk about We Care, because that's really my heart. But I love my doctors, and so let me tell you a little bit about the Lake Sumter Medical Society, which has been here for a long time, in case you don't know it. It's a membership organization for MDs and DOs. The Medical Society advocates, supports, and assists doctors in the practice of medicine. We take seriously legislative and political matters that affect their practice and their patients, and we try to work hard to help them maintain their scope of practice, which is a real hot item nowadays, and of course the Accountable Care Act. I too am conflicted. I also wear two hats, and I have two different areas of concern, and my physicians are often rather conservative in their thinking, but then I have my We Care side, which is not. So I wanted to tell you a few facts, just some numbers here. $2.3 million. That's the amount, $2 to $3 million, excuse me. That's the amount of economic impact generated by a physician in 1 year. 59% of all physician visits in a year, 59% are to a primary care facility. 40, that's the number of medical school graduates from UCF next month for their first graduating class of medical doctors. 1,663. That's the number of doctors in Lake County. 1. That's the number of private practice primary care physicians in Umatilla. So, you know, those are some good numbers, I thought, that you would find interesting. I interviewed a lot of doctors about what they thought would be the direction that we should go when we're looking at what we're facing, which is a physician shortage in Lake County. And frankly, you know, it kind of went all over the place, but mostly they were frustrated and a little bit skeptical. They are in the moment, and Dr. Boardman is going to, I know, tell you a little bit more about it, but they are dealing with things that are in the moment that are critical. They are having challenges with Medicaid, and they are having challenges with all of the new rules and regulations that are upon them. they're expensive, they're time-consuming, and it is hard for them to maintain a business, because guess what? All of these doctors are small business owners. They may be a single solo practice, or they may have multiple doctors, but they are business in our community, and they generate revenue. That goes back to that $2 to $3 million in revenue. They are engines. So the doctors that I spoke to really didn't have an answer. You know, I'm not really sure what the answer is and how we're going to get doctors here. But this is what I know, that because every doctor generates this much income to us, that is powerful, and it begs to be recognized. So my question is, why aren't we working really hard to bring in doctors, to make those doctors that are here want to stay? Why aren't we, when we find out that a physician is leaving, why aren't we beating a door to their path to say, why are you going, and what can we do to keep you? And I have a case in point. I have a physician that is leaving in 2 months. She's closing up her office. She's going away. She's going to be moving up north. This is a big deal. That's $2.3 million a year that we're losing because she's moving her practice. She's not going to be employing doctors anymore. She's, you know, the practice has the capacity to totally dissolve. That's really a big deal for us. And then the flip side of it is, we have a new doctor down in Claremont. She just joined an ophthalmology group, and she's in heaven. She loves it here. She loves the hospital. She loves the work, the practice, the people. She's in you know, so we've gone from one end to the other, that we have to recognize that we want to recognize this doctor that is happy and use her as our model, and recognize the physicians that are struggling, and find ways that we can help them to keep them here so that they don't go away. This is not just a problem for Lake County. I know it is not just a problem for Lake County. So what are other people doing? What are other counties doing? What are other states doing? And what can we do to think outside of the box, give them breaks, give them incentives, give them something to make them stay? And guess what? We can have We Love Our Doctor Day. It's a little hokey, but you know what? Doctors talk. And I think that when they feel that they are recognized and appreciated, then we might just keep them. They're an engine, they're worth their weight in gold, and we really truly need to make sure that they stay. I did prepare, this is not nearly as fancy as the PowerPoints, and forgive me for that, but there is something that I did prepare for you. And on the back of it is an extremely simplistic little graph on the impact of a physician to the community, because they hire, they have a business, but then there's the flip side of it, they have patients, and the patients generate income, generate funding and revenue within the community. So it's a huge thing that most people don't realize, that I believe physicians generate more income within a community than any other business person. You know. So with all of that said, I've rambled. Dr. Jason Boardman happens to be my board president for the Lake Sumter Medical Society, as well as We Care. He's been around a while. He has been to Afghanistan. He is a surgeon now in Claremont. He has a family and 2 young children and a lovely wife who also happens to be a physician. And so I'm going to turn this over now to Dr. Boardman.
Hi. First of all, I want to apologize for running late, but I was actually doing surgery this morning. I also don't have any slides to present. I didn't realize that that's kind of the format that this was going to be. I just want to start just by kind of going backwards a step in what led to the Affordable Care Act. You know, there's an old saying, he who controls the information has control. A lot of the information that was passed around to the general public before the Affordable Care Act was passed was true, but twisted. Let me give you some examples. Everybody's heard where we stand in the World Health Organization's ranking of countries as far as medical care. Anybody have a rough idea of where that is?
15 or 16.
more like 26. Do you know what that statistic is? What it's made up of? Okay, there's the problem. That statistic takes into things that are somewhat arbitrary. For example, in this country, we have a higher infant mortality rate than almost any other country in the world. The reason being, any child born at 25 weeks or later is considered a live birth. And we do everything in our power to try to get that child to survive that first year of infancy, because once they get past that first year of infancy, then the infant mortality rate drops. In most other countries, especially in underdeveloped and third world countries, a child is not considered a live birth unless it's born after 36 weeks. So we're comparing apples to oranges. So our infant mortality rate is much higher. Why? They're live. They're not live. Even though they may be breathing and born at 28 weeks in that third world country, it's not a live birth at that point. So the statistics can be manipulated in such a way that you can have it show anything. The other one that I always like is...
Let me say something. That wasn't meant as an attack or a bias. I read an article and I thought that's what it said.
Yeah, I don't remember the exact numbers, but it's one of the reasons that we're not number one. Now, the other statistic I always like, and this is the most arbitrary of the entire organization rankings, is anybody know about how many CAT scanners per 1,000 people in this country? We have about 117 CAT scans for every 100,000 people, I think it is. It's a huge number. The closest is in the 10s to 20s. And I don't have the exact statistics because I didn't, like I said, I didn't have all that. Now, the problem is we don't have equal access to that CAT scan. If you can afford it, if your insurance will pay for it, then you can get a CAT scan fairly easily. If you're an indigent patient who doesn't have insurance, doesn't have the funds, getting a CAT scan is going to be very hard. Well, guess what? Most third world countries and underdeveloped countries, they may have 1 or 2 CAT scanners for every 100,000 people. But it's equal access across the board. Nobody's getting them. That gives you a higher ranking. Wait a minute. It doesn't make sense. And so the statistics of what was used to, and my conservative side is going to come out, ram this thing through, were based on false statistics. Now, if you listen to the President during his State of the Union address and also his speech to the AMA, he gave a lot of lies, actually. You know, one of them was a surgeon getting $26,000 for doing an amputation. Yeah, right. I'd do one a month and I'd be happy and I'd be set for life and I wouldn't have to work real hard. That's not even close to being the truth. The $26,000 may be the entire charges for that patient's stay, including the hospital stay, the surgeon's fees, the anesthesia fee, the pathology fee, any labs that he has done, any medications he gets while he's in the hospital. That may be the entire charge for the entire procedure of that patient during it, but it certainly is not going to the physicians. So again, the information that was being passed around wasn't really accurate. So we all have to understand that that's where we're starting from. So if we look back and say, okay, where is the real problem? Do we have a healthcare problem in the United States? If you look at cancer survival for breast cancer, colon cancer, lung cancer, you name it, we're number 1. Cardiovascular disease, I think we're either 2 or 3 in the world. Some of the other more common diseases, we're in the top 5. Diabetes, we're a little bit lagging. But if you take that number and look at it, which is you get diagnosed with a disease and you're alive in 5 years, wow, that's pretty important. That would be, to me, the most important thing. And we're in the top 5 in almost every category. So we don't have a health care problem in this country. We have who's going to pay for it problem in this country. Okay? Now, where does that stem from? Well, back in 1963, Medicare was developed. Medicare was developed in order to be a supplemental insurance for our elderly population in order for them to be able to afford health care. It was not meant to be the only insurance for our elderly population. Well, over the years, that system has been manipulated that now it's the main way for our elderly population to pay for their health care. Wait a minute. Again, there's a problem there. Okay? We have a lot of people who can't afford health insurance. Why? Health insurance is very expensive. If you're an individual trying to find a policy for you and your family, not through a business, not through an organization, forget it. You're talking several $1,000s a month to be able to afford basic health care. Well, if you're a young, healthy individual, you know what? Let me get sick and I'll save that $10,000, $15,000 every year, and if I get sick, I'll have the money and I can pay for it then. Makes more sense. Okay? The other thing is, what is insurance? Insurance is not meant to pay for your everyday things that you use in life. Your car insurance doesn't fill your gas tank. Your car insurance doesn't change your oil, doesn't buy you new tires. That's called maintenance. You pay for that yourself if you want your car to run over a period of time. Why do we think health insurance should be any different? Health insurance now gives you that maintenance. You go to your doctor for your routine visit, you go to get your mammogram if you're a woman, you get your colonoscopy at the age of 50, you get your maintenance exams to keep you healthy. But that's not what insurance really is. Insurance is there for that catastrophic problem that may develop where you need help to pay for it. Get in a car accident, you need to get your car repaired, guess what? Your insurance is there for you then. Again, there's a disconnect in what is insurance, what should we as individuals be paying for, what should our insurance company be paying for. The more we ask of the insurance company, the more they're going to raise our premiums. They've got to run a business, just like the rest of us. You know, we all have jobs. We're either in business for ourselves or we work for somebody, but if you're working for somebody, the owner of that business needs to earn money. They need to earn a living. And yes, there is a very large disconnect in some of the wages that people earn around this country. Our CEOs of some of the major insurance companies are making tens of millions of dollars a year. You know what? Do they deserve it? That's not for me to answer. That's just business. Okay? So with all of that in mind, as a physician, as a small practice, okay, I'm a general surgeon in Claremont. I was in solo practice for 5 years, merged my practice with another group, and now there's 5 of us in the group. My wife has her practice. She's a group of 5 OBGYNs also down in Claremont. I've learned the hard way what it is to be a business. The doctoring's easy. You might think that that's the hard part. After spending 4 years in medical school and 5 years doing further training, the doctoring's the easy part. You know, I can do a lot of that in my sleep. Running the business, that's the hard part. And the problem is, it's not a healthcare problem that we have. It's a business problem. It's who's going to pay for people to get the care that they either need or require or that they want. Okay? So, as physicians, the Affordable Care Act puts a lot of new burdens on us. Okay? The first one is, and it actually wasn't part of ACA, I think it was part of the stimulus package, is the mandatory requirements to use EMR. And they say, oh, it's not mandatory, we're going to give you a bonus, you know. And what it is, electronic medical record is, I go into my office and we have a computer, and I can put all of your information into that computer. And the idea is, it's supposed to work like the internet. My other doctor friends, if I send a patient over to Dr. Smith over here for a referral, that doctor can get access to that patient's records and know what the heck has been going on without us having to fax things back and forth or make phone calls. It's easy access to the information. It's supposed to work that way with doctor referrals. It's supposed to work that way with lab, x-ray, pharmacies. The information for every patient should be free-flowing between all these people who have to take care of that. And that's a great idea. The problem is, it doesn't exist. The internet for medical exchange of information does not exist. But the government says, we're going to make it exist. We're going to force it to exist. And to help you, we're going to give you over a period of time a certain number of dollars. Guess what? Those dollars don't cover the cost of doing an EMR. Okay? GE came to our hospital 2009, 2008, I don't remember the exact year. And they said, we work with Orlando Regional really well. We're willing to offer them a discount on our EMR called Centricity. When you added it up, it was roughly between $1,500 and $2,000 a month to use it per physician. Doesn't seem like a lot of money. Okay, over a year, that's $24,000. Over the 4 years of the stimulus money that you were supposed to get for instituting these EMRs, I think the total over 4 years was $44,000. Let's see. 44 over 4 years, and I'm spending 24 a year. I'm going to lose $40,000 over the next 4 years. Okay. But if I don't do it, then the government's going to say, for all my Medicare patients, I'm going to get a 1% penalty for the first year in 2016 or 15. I don't remember the exact year that the penalty is supposed to come out. 1% penalty on the payments I receive from Medicare. So $40,000, say, we'll take 1 year. Say I get $20,000 penalty. I'd have to collect $2 million just from Medicare to offset the cost of my EMR. Guess what? As a business owner, that doesn't make a whole lot of sense. I don't even come close to collecting $2 million for all of my patients in a year. Okay? So the thought process of the way this was instituted just doesn't fly real well in the face of business. Is it something we should do? Is it something that may help us take better care of our patients? Yeah, I will tell you in the future, when it's more like the internet, where you can go in and log into a secure bank and do your banking online, and nobody has access to that but you, or somebody you give that information to, then it'll work. But right now, without that system, it's very hard to make it work. So that's a challenge that all physician offices have to face. And the problem is, as a specialist, as a surgeon, I see a patient, pre-op I might see him, they come in with a hernia. See him once, talk to him about what the disease is, offer to fix it for him, do the operation in a hospital or a surgery center, they come in for 1 or 2 post-op visits, and I don't have to see him again usually. The EMR that I might use isn't going to be the same for the primary care physician who has somebody who has hypertension that they need to see every month to manage their hypertensive medications, or every 2 months, or the diabetic. Completely different. And then the other thing that happens is, you know, you go to your doctor, and how many people here have diabetes? Anybody? How often do you see your doctor for diabetes?
About every 4 months.
Right. Pretty much the visit is pretty much the same every 4 months for your diabetes. Goes over your sugar levels, says, okay, we need to adjust your medication whether you're on insulin or orals, but it's pretty much the same visit every 4 months. Would you agree?
It is.
The government is now looking at these, what we call cut and paste or template notes in these EMRs, which are pre-generated notes where you've either taken the patient's previous note and moved everything forward and changed 1 or 2 pieces of information that are applying to today, or you have a template for a diabetic visit that basically goes through all the questions that you normally ask, because you do the same thing all the time. The government's now looking at it and saying, well, no, we're not going to pay for that anymore. You're doing the same work over and over again. How do I know you really did that work now? So another reason physicians, and a challenge that physicians are facing, is every time they institute more and more regulations, it's just a way for the federal government, the private insurance payers to say, haha, guess what? We're not going to pay that because you didn't follow our rules. It's a very difficult situation. There are other regulations out there. There's one called the red flag rule that most people don't even have any idea about except for physicians, and thank God it's been postponed and postponed and postponed. But the federal government considers physicians loaners of money. Do you know why? Because you have insurance. And I don't collect what I bill you the time at the visit. Because we have contracts with insurance companies and say, we'll bill your insurance company. So we bill your insurance. We're extending all of our patients credit. So now we're considered the same as a bank. And all of the protections that the banks have to have, guess what? Physician offices now have to have. Wait a minute. You know, we're not creditors. We're not loaning people money. We're not delving into their finances and saying, well, you qualify for this loan or not. No. We're trying to help them get the care that they need through their insurance company. But the government doesn't see it that way. Because we're not collecting everything that's owed to us up front at the time of that first visit or the time of each visit, we're considered a creditor. So the institution of that in each office is estimated to run between $10,000 and $50,000. Okay? ICD-10. Anybody know what ICD stands for? International Code of Diagnostics. It is the codes we use that gives us a number that equates to a disease. For example, gallstones, 574.20. Gallstones unspecified. You have gallstones, you come to see me, I use that code a lot. Well, there's a new one coming out called ICD-10. It takes, most primary care physicians have something called a super bill. It's a piece of paper that they have that they circle the common diagnoses and they give it to their front desk and then they put the information into the computer. The average primary care has a 1-page super bill. When you convert that to ICD-10, it becomes 10 pages. The cost of implementing ICD-10 is estimated to be, for a single solo practitioner, $50,000 to $100,000. For a small multi-physician group, anywhere between $100,000 and $200,000, and for a huge conglomerate group, it's $200,000 and above per physician. Okay? And does that help me practice medicine? No. What it does is allow people to delve into the data that we collect as physicians. That's it. It doesn't make my job any different. So all these regulations that are constantly being thrown at us are things that we have to do. Every time I have to spend $50,000 on a new EMR or $50,000 to implement the red flag rules, $50,000, $100,000 to switch to ICD-10, that's $50,000 out of the practice. That's potentially hiring that new physician. And yes, we do have a tremendous physician shortage in Lake County. Mostly in the primary care field, pediatrics. We certainly have some specialists that we really could use more of, endocrinology, rheumatology. You know, hospital bed-wise, I know that South Lake during the winter months, usually from about end of September, October until March, April, we run at 130, 140% capacity. We don't have enough beds in the hospital to fit the needs of everybody. We have trouble getting people to rehab. We have trouble getting people to nursing homes. It's not a matter of people not getting the care. It's a matter of how do we make it easier for people to get the care and who's going to pay for it.
Thank you, Doctor. At this time, I would like to introduce Mr. John Cherry. John Cherry has been President and Chief Executive Officer of LifeStream Behavioral Health Center in Leesburg, Florida, since June 2000, and in that capacity operates a nationally accredited psychiatric hospital and community behavioral health system. The company employs approximately 575 people with a fiscal year 2012 revenue base of $34 million. John is a CPA and a graduate of the University of West Florida in Pensacola. He has 37 years of financial and administrative experience and came to LifeStream as a highly experienced behavioral health care executive with a leadership background in several large community mental health centers in the state of Florida. Just prior to accepting his position to LifeStream, he was Executive Vice President of Lakeside Alternatives, Incorporated in Orlando. During John's 12 years as LifeStream CEO, the center has had several important accomplishments. It created the I Support LifeStream campaign to raise awareness of the provision of mental health services which benefit our community. LifeStream successfully completed requirements to qualify for Phase 1 federal meaningful use incentives utilizing our electronic medical record system. Chosen by the National Council for Behavioral Health to participate in the National Trauma Informed Care Learning Cooperative. This complements the work with the state of Florida in this area. Continued work with South Lake Hospital in Claremont to design a new integrated health campus to address primary care and behavioral health needs of the individuals they serve. Re-implemented psychiatric services at Langley Health Center, a federally qualified health center in Sumter County. Received neighborhood stabilization program funding from Lake County to purchase and renovate 3 homes to use as housing for disabled adults. John lives in Yalaha with his wife Maggie. He has 3 children who have all blown the coop. Yay, yay, yay. I know what that's all about. As long as you're not paying for the college. And thankfully, he says, thankfully living their own productive lives. That's always great when they don't have to come home and grab money out of your own pocket. At this time, please welcome John Cherry.
Thank you. I don't have as good an excuse as Dr. Boardman for being late. I wasn't in surgery, but I discovered that we don't have a high-speed printer at LifeStream. And as I was printing those 100 copies this morning, it took a little longer than I expected, so sorry about that. But all of you should have a copy of the outline of the presentation at your table. I also brought annual reports of LifeStream and our directory of services. They'll be on the table outside if you'd like a copy of those as you leave. Behavioral health centers such as LifeStream. There is currently minimal federal oversight of comprehensive behavioral health centers. President Reagan in 1982 block granted the dollars that had been coming directly to behavioral health centers and basically directed those dollars to the states. We do have a current effort in Congress to establish what are known as federally qualified behavioral health centers. They would complement the federally qualified health centers that are in place. We have one here in Lake County and one over in Sumter County. It would provide a recognition, which is not currently in federal statutes, for the definition of what a behavioral health center is and what the expectations are. So we're hoping that passes Congress this session. It's the third year that it has been presented, and again, we hope that it is approved this year. So what we have right now are state-by-state systems. Every state has a different type of system, different laws governing behavioral health services. The Florida system, we have 40 comprehensive centers like LifeStream that operate across the state. In the urban areas, we have separate centers for mental health and substance abuse services. In the suburban and rural areas, such as Lake Sumter counties, we have one comprehensive center, and we are responsible for providing all of those services to any citizen in Florida that needs the services. So all of the services are provided based upon a sliding fee scale. Probably if any of us were to request services, we'd be paying 100%. For individuals that are 200% of the poverty level, they might be paying 5% as their copay. So LifeStream has about 525 full-time equivalent staff, about 600 employees, and that's everything from psychiatrists, nurses, social workers, down to our clerical folks and the site techs in some of the residential units. Again, the services guide, which will be outside, identifies the 40-some-odd programs that we do provide. We have a psychiatric hospital over on Talley Road here in Leesburg. That is a 62-bed inpatient facility. We have 9 different residential facilities, primarily for mental health, but a couple of substance abuse facilities. We have rehabilitative services facilities, outpatient. We have 3 separate outpatient clinics in Lake County, and medical services that permeate all of those services. We see ourselves as a giant prevention and treatment system. I say prevention because let's go back to 1955. Florida had 4 million individuals living here. Of those, 55,000 individuals were in state long-term psychiatric hospitals. 55,000 of 4 million people. Here we are today with 18 million people. There are less than 600 individuals in those civil beds. Why? Because we have a comprehensive system of community care with centers such as LifeStream. If we didn't have the community system of care, the state would probably be bankrupted because it costs for community care for severely ill individuals with severe mental illness or severe substance abuse problems. It costs about $15,000 per year to treat those individuals in the community. One bed at a state inpatient facility today costs $125,000 per year. So we are providing care for those individuals in the community, much more cost effective, and of course in a much more humane manner, we believe, keeping individuals close to their families and others that can help care for them. You see all of the facilities that we have in Lake and Sumter counties. Primarily, our facilities are in Lake County. Historically, that's where the population was. But overall, we have about 22 different treatment facilities. And again, that's from outpatient, residential, to inpatient. Mental illness and substance use disorders. We had 297,000 individuals in Lake County, according to the Florida Statistical Abstract in 2010. So we have a few more folks than that now, probably a little over 300,000, I suspect. Of those, the majority were women, probably 51-49. By age, we had 20% of the individuals living here were children, 17 and under. 23 to 24% were elderly, 55 and over, and the remaining 163,000 were adults, 18 to 65, I'm sorry. The breakdown by ethnicity, we had 73% of the individuals here were non-Hispanic white, 13% Hispanic, 10% non-Hispanic black, and 4% other, I assume primarily Asian. The disorders themselves, the population with a diagnosis of severe mental illness in any general population, approximately 3% will have severe bipolar disease, 2% schizophrenia, 2% anxiety disorders, and 1% severe depression. So about 8% of the general population worldwide, regardless of the society, has a severe mental health disorder, mental illness disorder. Severe substance use disorders, about 9% of the general population, 6% severe alcoholism, and 3% other drugs. The other drugs are gaining on the alcoholism category. That means approximately 24,000 individuals in Lake County have a diagnosis of severe mental illness, although they may not be diagnosed, but have a severe mental illness. Approximately 27,000 have a severe problem with substance use disorder. About 70% of those populations are dually diagnosed. It means if one has one, they have the other. Not all, but about 70% of the populations that are served. Again, Lake County population, 297,000 individuals. The approximate percentage that have severe mental illness and or substance use disorders, about 10.5% of the population. For Lake County, that's 31,000 people. The estimate of the number that are actually receiving services for those disorders, about 10,000 individuals in Lake County. So it's about 32% of the individuals that need treatment are getting treatment. Many reasons for that. We'll talk about some of them later. But it leaves an untreated population of about 21,000 individuals. Those numbers, 32% or so with the disorder that are being treated, is fairly consistent across states. But that is the number per Florida. The estimates of the uninsured, you may have already gone over this, but in the state of Florida, 1 million who potentially may have Medicaid under the expanded health care that's been recommended. It depends on the legislatures, you know. Either they will or won't have Medicaid or something that looks like Medicaid. There's another 2 million individuals out of our 4 million of uninsured in Florida that are potential exchange individuals, folks who will go to the insurance exchanges and get some kind of coverage. Not sure what it will be yet. And it's going to leave an estimated 1 million individuals who still will be uninsured. And that will be either because they refuse to get insurance and they will pay penalties through their tax returns, or whatever the reason is. But of those 35,000 or so, that if the legislature passes some coverage for them, and then the folks going to the exchange, 45,000 individuals, I would anticipate that about 5,000 more individuals with severe mental illness and substance use disorders will have coverage. And that's the 10.4% of that 45,000 individuals. So 5,000 more that will have coverage, maybe more. It depends upon what the allocations are within the populations that get insurance. If the trend continues, then 32% of those individuals will seek treatment and actually either come to us or other treatment professionals in the community. Then we're talking about an additional 1,440 individuals that will be getting treatment. That's an increase of about 11.4% from where we are right now. Individuals who are actually getting treatment. It's about an 11% increase. For LifeStream, that means that we will have to increase our staffing by about 60 individuals. And those will mostly be professionals, psychiatrists, nurses, social workers, master's level counselors. So that's a challenge. It's a real challenge for all of us because it's very difficult. The reimbursement rates aren't what they should be in order to attract individuals into this particular field. And so it's a challenge. But I looked at, when I came to Lake County in June 2000, we had about 250 staff, and probably 70% of those were professionals. 250 staff. Well, today, we have 525 staff. So how did we do that? Well, we did what we all did. We advertised, we did what we needed to do to attract folks, the professionals that we need to provide the services that we're being reimbursed for. We were able to attract 275 more staff over the last 13 years. So I have my doubts when I hear folks say that because there's increased ability for individuals to get health care who might not be getting it now, who really need health care, then I believe that we're going to be able to attract folks to Lake County, the professionals that we need to be able to provide the services. For me, 11% more is not going to happen in 1 year. There's going to be a gradual increase in the number of individuals who are actually getting insurance. And again, I would see, personally, I believe it's going to be 4 or 5 years before we get to these levels. And I have no problem in being able to attract the professionals that we will need in order to provide the services for those that want services. Keys to treatment for these diseases. The remaining untreated population in Lake County will be about 20,000 individuals. Folks that really should be getting treatment, but that aren't for many reasons. Well, the question is, how do you identify those individuals? How do you screen them? How do you convince them to come into treatment? The problem with the mental health system in this country, and there's positives and negatives to this, but basically an individual, if they are not dangerous to themselves or others, qualify under the Baker Act in Florida, you cannot treat. Even individuals that come to our hospital and are brought to us by law enforcement, they can refuse medication. They can make it very difficult to get treatment if that's what they want to do. And by law, we are required to acquiesce to their wishes. So, 3,000 to 4,000 individuals a year that we treat inpatient under the Baker Act because a law enforcement officer or a mental health professional has deemed that they are dangerous at that point in time to themselves or others. They're with us for acute stabilization, 3 or 4 days. They're back into the community. All treatment past the Baker Act is voluntary. And so think about our health. We don't always go to the doctor when we want, and we have our faculties about us. So it's very difficult, and that is one of the problems that we have. On the one side, completely understand why we have it, because it needs to be voluntary. Adequate funding and the rates of reimbursement. We can have, in total, adequate funding, which we may under this new regimen that we're going under. But the key is, what are the reimbursement rates? And right now, most of you know the reimbursement rates under Medicaid are horrible. State sets the reimbursement rate. Every state sets their own regimen of reimbursement rates. Medicare isn't a lot better. They are better, but not a lot better. And so that's going to drive who will be able to provide these services. There's a reason in our field there isn't a lot of for-profit activity. Reimbursement rates. And so it falls to the nonprofits to do their provide care the best they can with the rates that are provided. Detriments to treatment. I've talked about the voluntary versus involuntary. Again, it is why a number of folks don't get treatment. There is still stigma involved, as we all know. We have the chairman of the Appropriations Committee in the Florida Senate who publicly will tell you that substance use disorders are not real diseases. And the science says that it is a real disease. I mean, it's overwhelming. But anyway, so you have high-level folks who don't believe that substance use disorders are a disease. I think folks don't believe mental illness is a disease. But it is. And so we have that to overcome. So if you're an individual, I'm living in society, do I want to be tagged as mentally ill? Probably not. So, and it's because of the overall stigma that is there in our society. And it's human nature. Understand why. But we all should make a better effort to reduce the stigma surrounding these diseases. The general resistance to treatment. Again, medication adherence. General population, we go to our doctor. When we get to the doctor, especially we men, we get a prescription. General population, 50% of the prescriptions that are given to patients aren't filled. We're not very good because we don't really want to take medication, many of us, even if we should. So a detriment to treatment, especially with the populations that we serve. The future, it appears to me that resources will be available for those that want treatment. So we're going to be there, we're going to be available to the individuals that want treatment from us on an outpatient basis, and of course for those that require the inpatient care. There is a glimmer of hope. Mental health first aid is a program that is like regular first aid, but it passed Congress yesterday. We hope it gets through the House. It will provide some dollars for training of the general citizenry, first responders, others, about the signs of mental illness and what to do if you see those signs. Many of the tragedies that we've seen in the last couple of years, there were signs, people saw them, they didn't follow through to get the person into treatment, and it could have made a difference. The integration of behavioral and physical health care, the folks that we serve die on average 25 years before the general population, before you and I. 25 years before. One of the major reasons for that is they don't get primary care. So a number of us throughout the country were successful in getting Congress to do some pilot projects across the country. Livestream was one of the first 56. There are currently 95 of these projects where the federal government is providing grants to provide primary care to the individuals we serve who don't have a medical home. And we believe that we can make a huge dent in that medical disparity of those individuals dying 25 years before they should, before the normal population. We are in the forefront of that effort. We are basically going to co-locate primary care physicians, RNPs, PAs in our psychiatric clinics, provide primary care service to those individuals that don't have a medical home. We're glad if they have a medical home somewhere else. Don't have any problem with them doing that, but it's problematic getting them to the appointments and then sometimes at the facility. And finally, technology. The internet apps, there must be 100,000 of them already for folks to take this test to see if they're depressed. Many, many different apps. And some of those are very good, and it's going to help. It's going to help people realize that maybe they do have a problem, and they need to get it checked out. Pharmaceuticals, they're getting better and better. There are other technologies that are coming online that are going to help to diagnose. Genome surgery is right around the corner. They're identifying now specific genes that are the causation of certain mental illnesses. And in our lifetime, there will be genome therapy to help with that. So, many, many positive things that we can look forward to. It's never easy for any of us. But working together with, I listed all the partners also that we have. And again, it takes all of us working together. We can make a dent in the illnesses that we serve, the individuals that we serve, these illnesses. So thank you very much.
Thank you, Jeff. For those of you who might wonder why we haven't talked more about the specific topic of the meeting, the Affordable Care Act, and how we need to be prepared for its implementation, let me just share that during this mapping process, the mobilization and the meetings we've had before in the community development of where we are now, we really haven't had an opportunity to have these very important health components of our community actually tell you their own story in their own words. So maybe this is a little bit kind of catching up for some of maybe what we could have had a little bit earlier in the process. But we will ask specific questions about the need for providers. We have some statistics, the issues of how many folks know that they are eligible for coverage. But before we do that, and we may have to truncate a little bit of that, most of that is already in the PowerPoints. So if you take a look at those PowerPoints, the people leaving this room will know more about the Affordable Care Act and the impact on Lake County by reading those PowerPoints rather than us trying to skim over it faster than we have time to do. But I think there is someone who's traveled quite a distance and someone who we are tremendously pleased to have join us, and that is Debbie Wright. Debbie is with the Florida, I still call it Department of Health. Is that what they call it? I don't know, they keep changing the pictures and stuff. Department of Health. Debbie is the section supervisor of the State Primary Care Office, and she is a State Primary Care Officer. Debbie has over 15 years with the Florida Department of Health, serving in a variety of positions with tenure in staff development, training, immunizations, community health improvement planning, and presently the Primary Care Office. She is currently responsible for the state health professional shortage designations, all those things that those people who get loan repayment consider very important. So if you don't like that, Debbie is right there, but I won't give you her telephone number. The foreign doctor waiver programs, the National Health Service Corps, again, a very important program, and Debbie is kind of the conduit and the connector between all those programs. And the Community Expanding Access to Care Grant Program for the Federally Qualified Health Centers. Debbie has a master's degree in community health science from Ohio State University and a graduate certificate of health administration and policy from Florida State University. So at this time, please welcome Debbie. We appreciate her driving 4 hours to get here.
I want to say we're the State Primary Care Office within the Florida Department of Health, but sometimes I get a lot of feedback from different other managers and supervisors and such in the Department of Health saying, we don't have a primary care office. But the federal government looks at my office as the state primary care office. Every state has a primary care office. And so my designation, according to the Health Resources Service Administration, my real title is I'm the primary care officer for Florida. So Wally mentioned a lot of the programs that we have. And, these are programs that have been around for decades. And unless maybe you're a practitioner that's been a beneficiary of these programs, or you are a health facility that has taken advantage of these, a lot of people don't know about them. I've got my PowerPoint here, and I'll say I was late getting it in, and I apologize for that, so I don't have the printouts. However, it's a reflection of, for the past year at the Department of Health, I've been filling the role of probably 4 full-time employees doing all this work. We've had our National Health Service Corps coordinators been out on maternity leave. We had 2 people resign, and the federal government doesn't care about that. You still have to keep going. So I put this together and finished it. So Wally, are you doing the...
You don't clicker, but you just point at me and I'll do it. Or just
Oh, okay, so that's how it works. So the hub to all of our programs are what's called the Health Professional Shortage Designations, and HPSA is the term for it. And then there's also another designation that is given as medically underserved areas, and we have medically underserved populations. But the most useful, I should say, is getting a HPSA designation. And in Florida, there are 692 HPSAs. And a HPSA, they're very complicated how we have to process them. We have to do it through a software program from the federal government. We have to survey communities, and we have to check Medicaid data runs to find physicians that are Medicaid providers and find where they are and so forth. So a HPSA really is a cluster of census tracts that we call a rational service area. And we look at them for certain factors. One is the percent of the population that's 200% below poverty, the infant mortality rate, the physician to population provider ratio, and there may be one other. But anyway, it all gets folded in, and the Health Resource Services Administration assigns scores to each one of those little indicators, and then we calculate and upload data, and voila, comes your HPSA score. So, and it can take sometimes, some of these applications take us 2 and 3 weeks to do, and then once we submit them to HRSA, they take months before HRSA comes back and tells us that it's been approved. And they have to be redesignated every 3 years. So our office, on a daily basis, is constantly doing HPSA designations, since we have so many of them in Florida. Just a little side note, yesterday I was at Shands Medical Center, and I went there to go visit some of the foreign doctors that are on our program here. And
you know, they were just saying that they have concerns about the Affordable Care Act, and so when I look at my programs and I see the clinicians that are in there, and I hear what they're saying, in general, I can just say it's a lot of uncertainty, you know, on a lot of parts. But our programs, no matter what, they're there to really uphold the real safety net, the real, true safety net, and they always have for decades. So these are Florida HPSAs by type. This map that you have up here now, geographical HPSA, the blue ones, they're kind of also considered like whole county HPSAs. As well, there's the single county ones. Single county ones, I'll start with those, the pink ones. If you look at that, you can see that those counties that are in the pink are areas that are the most, let me just say, I guess, they're really very rural, they're very isolated. They have a really lack of providers, and so, and small populations in general, and so their whole county is ahead. Whereas some of the others, the population group ones, like, let's say, let's hear it in Lake County. I know that we'll get to this in a few minutes, but I think you only have one HPSA. It's not a whole county. It's called a low income, special population, low income, and it might be low income migrant farm worker. Again, I'll go back to it. It's a cluster of census tracts that the people that live in those census tracts all kind of have the same ethnicity, or they have the same poverty level. They are and the census tracts are contiguous. And so we try to look, when we build these HPSAs on the maps in the software system, we try to include like as many of the area census tracts as we can, but sometimes we just can't, because if we, let's say for example, there's a census tract that has, like, you know, the over the tracks kind of theory, like you go over the railroad tracks and suddenly you're in this high income area. So if we added that census tract, you may lower your HPSA score. We know that the purpose of getting a HPSA score is so that you can qualify for National Health Service Corps loan repayers to work in your facilities, so that you can qualify for applying, like if you have a federal qualified health center in your area, they can qualify to apply for grants, and they become more likely to get those grants if they have a higher HPSA score. So we try to do our best and represent it as well as we can. So you can see, can you go back just a minute, Wally? But you can see overall that Florida has a lot of HPSAs, and the places that don't are, places like Flagler County or Monroe, because, mostly because of their percent of 200% below poverty doesn't make it. It has to be 30%. And I've had some cases where they're right at, I had one, it was a HPSA in Hilliard, Callahan-Hilliard, which is in Nassau County. And it was their poverty rate, based on the software in the HRSA system, which is uploaded from the Census Bureau, it was 29.89. And I called my project manager and I said, really, can we not, like, she goes, nope, we have to have our cutoff. And so I tried, and I said, unless you show us there's severe unemployment or there's something going on there that we can push it to the 30. But anyway, it has to be 30%. But if you think about that then, and you look at all the HPSAs in Florida, and you think about the Affordable Care Act, there are a lot of people. And there may, I guess it was yesterday after talking to some of the physicians at Shands, their minds were going thinking there might be a lot more than 4 million that are going to need to be entered into the Affordable Care Act. There might be a lot of patients that they may be considered uninsured right now, and they may be maybe being classified as that they're not Medicaid. But once you start employing a lot of financial eligibility workers and patient navigators, we may find that even without the Affordable Care Act, FQHCs and hospitals are finding that when they do screen these patients, they qualify for Medicaid, but the patients never knew it. So,
actually, Debbie, the statistics are about 17% of the people who are eligible for Medicaid are aware of it. So in other words,
It's
there's
low.
83%
Yeah.
of the people who could be receiving access to some payment for services don't know.
They don't
And
know.
one of the biggest challenges that in the Affordable Care Act is how do you get the word out to people what they're eligible for. 22% of the people who are eligible for the expanded new health insurance coverage are aware of it. You know, I mean, 78% of them have no clue. What the federal government has announced as of April 9th is that they're going to be spending $54 million to create insurance navigators for communities throughout the country. In Florida, they're going to spend about $5 million. These are going to be competitive grants. And in Florida, they believe it's about 3.5 million people that will, in fact, be covered. Incidentally, those navigator grants are going to be due June 6th. Communities have to put a letter of intent in by, I believe, May 1st. Today, this afternoon at 3 o'clock, there will be a webinar. HRSA and the Centers for Medicaid and Medicare are going to talk about stuff. We've got some frequently asked questions we'd be more than happy to share, because you're absolutely right. You hit on really what this whole thing is about. There is a shortage. There's a current shortage. There will be even a bigger shortage of providers, but we've got to make sure that if the folks that are eligible for insurance go for it, because if not, they're going to end up coming into the hospitals, and the hospitals have been cut. The hospitals are not getting the same funding for uninsured people, because the theory is that, in fact, hospitals are going to see insured patients. So the system has to be kind of whole. But again, at 3 o'clock this afternoon, Debbie, go ahead, I'm sorry.
Okay, and I'm just to summarize on HIPSAs. It's a very complicated process, but we do HIPSAs for primary care, and we do HIPSAs for mental health, and we have dental HIPSAs. Primary care, according to HRSA, is peds, OBGYN, internist, hospitalist, and family practice. So, okay, go ahead, Wally.
Quick note on that, primary.
And this is the ratio that they work on. You have to have one primary care doctor for every 3,500 within that low-income population. So again, it gets really technical. It's not just for the general population, it's for that low income. And the other trick to this is what these HIPSAs look for. It's all based on how many physicians are there that are accepting both Medicaid and sliding fee scale. We don't even count the ones that are just Medicaid only. So that's really what a HIPSA represents. And more and more and more in the past 6 years since I've been doing HIPSA designations, it is like really difficult to find physicians that take Medicaid and they have a sliding fee scale. And really the only places that those physicians are at are the federally qualified health centers in the state and at county health departments. And a trend I'm just noticing, and it's just all anecdotal, but I'm noticing it at work in my job from requests I get, is that we're beginning to see more, and this may be because the Affordable Care Act is doing more sort of faith-based related like primary care services popping up. Like there may be big churches that have thrift stores and they have social service programs, but more and more they're starting to find volunteer doctors, or they're getting doctors to work a couple of hours in the evenings for them. And so the request I'm getting is, are we in the HIPSA? Can we become certified as a rural health clinic? Can we become certified as, there's another designation for a type of facility, area of critical need facility, so that we can hire area critical need licensed doctors, which is a whole other program that we run. It's a limited license for physicians, but they have to work in an area of critical need facility. And so I've noticed that a lot more of my job is people calling for these requests, and then I'm realizing that they're faith-based types of organizations. So maybe we're seeing a trend that way, that maybe they want to make sure they're in a HIPSA, they want to make sure they get the proper designated facility by the government, so that then they can start taking Medicaid patients and they can, do the sliding fee scale. I'm not sure what it is, but it's been a burden on my workload. So, go ahead, and we'll go to the next. And this is just an MUA, it's a defined area in which residents have a shortage of personal health services. It's a little bit more general than a HPSA. Once you have an MUA or an MUP, you keep them forever, whereas HPSAs have to be redesignated every 3 years. We must pass through this, that's okay. And we'll keep going, because there's lunch on the table too. Okay, and another wonderful program of the federal government that, like I said, it's always been there, and now it's going to be really helpful with the Affordable Care Act, because really, the problem with one of the big glaring, and we've all talked about it, is the physician shortage. There's just a physician shortage and a real shortage of physicians that will take Medicaid and sliding fee. So there's the National Health Service Corps program. And our office, we don't do a whole lot of work other than we field questions from practitioners who want to become, they're new out of school or whatever, they want to get into the program so they can have their loans repaid. They don't get all of their loans repaid, but it's still pretty good. They can get $40,000 or $60,000 a year of their school loans repaid. They could be physicians, they could be PAs, they could be nurse practitioners, and clinical psychologists. So then the HPSA part comes into it, because you have to, and we also have clinics calling, can I become certified as a site? And there's deadlines for the National Health Service Corps when the door opens and closes for these applications, and so our office helps guide the clinic practice owners, and we help guide the loan repayers, the practitioners, on how to get their application in. And everything's so online now through portals, they have to register with. But they have to, because funding is getting squeezed by sequestration, and because it's very limited, every cycle that the door opens for applications, National Health Service Corps will make an announcement of what that HPSA score has to be. And last year, the HPSA score, you had to have a score of a 14 at your site, where you're located, in order to be able to be eligible to be a site, and in order for a practitioner to, apply to get loans repaid. So they have a wonderful website, and it's really good to look at. And and that's getting back to Lake County. Your HPSA's a 12, so it's like, that's not a possibility. And to change your HPSA score takes a lot. It takes a lot of, you'd have to lose like 2 or 3 physicians in order for that, score to jump up, things like that. So, but keep it in mind, it's a good resource. You never know what could change. Okay, we can keep going, that's okay, it's all the details of it. Okay, and that last slide was, we're on a grant. All my staff, I have 3 staff, and we're paid. We're all federal. I'd say we're federal workers. We're not, but it's paid through a cooperative agreement with Health Resources Service Administration. J-1 visas. Foreign medical graduates, they come to the United States. They're the most, as yesterday, the coordinator at the FSU, at the UF College of Medicine, she arranged for me to meet with the J-1, they're called Conrad 30 doctors, and they are, there's a Conrad 30 program from Senator Conrad, and there's 30 allowed in each state, and they have to apply to Florida, and they have to apply for each state. And Florida is a state that there's a high demand. It's very competitive for these foreign medical graduates to get a Conrad 30 slot. And it waives their obligation to return to their homeland, and so they want to stay in the United States. So we run that program, and we open up our door for applications in October, and we end it November 5th, and then we have a review team at the Department of Health that reviews all the applications. We have guidelines, and this year we changed them. We had to get a little bit more strict because we had 51 applicants for 30 slots, and we had 27 of those were primary care, and primary care is our priority. So as long as those 27 primary care applicants had all their paperwork and everything was fine, they automatically were recommended by Dr. Armstrong, the state surgeon general. And we had to go through a process of choosing the other 3. And they were specialists. I mean, so we had a scoring process for them and such. But they ended up, the top 3 scored high because on their applications, and it was noted, and we had to look it up on the Agency for Healthcare Administration data to confirm it, that those 3 specialists were going to be serving a high volume of Medicaid patients, and it happened to be in Miami, is where their employer is, University of Miami, and the medical center there. So for the first time in probably 10 or 15 years, University of Florida did not get all of their specialist slots that they applied for. So it's very difficult now to be a Conrad 30 if you're a specialist, because our priority is primary care. So we hadn't had that many. It could be a fluke of a year too, though. But Florida is very competitive. Doctors want to come here. These foreign medical graduates, they want to be here. And so it's kind of in contrast to what we're saying. We have this shortage, but yet we have this other group of physicians who they would give anything to want to be here. And I'll say Lake County has a lot of we have a lot of J1 visas here at the hospital. When we did it, I have a map, and I think I have it on here, but we mapped out the addresses. Yeah, here they are. We mapped out the addresses, and then we made this map. And the triangles represent the facilities where the employers, where they are. So the regional medical center has maybe 9 or 10 of them, but when you look at it, Alachua, which is University of Florida, they have 19. Let me back up, it's going so fast, but there's 30 a year, and they once they get their approval, they're good for 3 years. So at any one point in time, there are 90 Conrad 30s in Florida. So right now, Lake County and Sumter have a large amount, and we started to notice that there's a lot of employers here that attract these Conrad 30s. So, and then there's Miami, and then Gainesville. So that's a good thing. I mean, it's good that you have them here. It's really good. I was going to say yesterday that the thought slipped my mind, but the program coordinator there at University of Florida, she had all the J1s come and talk with me, and I got to meet them because I'm always looking at all their data on Excel sheets, and everything I see is on paper, and it was just so wonderful to meet them. But she said, I would like you to meet my politely persistent group of physicians here, because they struggle to maintain their waivers. They struggle to stay in this country. And so not only are they're working hard through their residencies and their fellowships, and then trying to get into the Conrad 30 program, then they're always on their mind is, what's my next step to get my green card, or my next step to become a citizen? So we want to encourage, this is a good source, especially with Affordable Care Act. I mean, it's a good source of practitioners. Only one of them yesterday, he was so happy, he said, I'm going to get my citizenship in about six months. So it was really nice, yeah. Okay. So these are just some resource links that I have: National Health Service Corps, the Office of Shortage Designations, and then our state primary care. I don't close, I know, because we have lunch, but I think this is something you'll all be really interested in. One of the other programs that my office was assigned to is called the Physician Workforce Assessment and Development Program. And the legislature passed a law in 2006 that required the Department of Health to, through the Board of Medicine, develop a survey, which is already developed, that when doctors renew their licenses every 2 years, so half the renewals that are done, that group of doctors has to take a survey, and it's an extensive survey, and it asks a lot of questions about their practice and so forth, and their intentions to stay in Florida. So we produce a physician workforce shortage report, and it's on our website. It helps the department and the state to track the shortages. It helps to track the maldistributions, and it helps us to see what is really keeping if there's a question that says, do you plan to retire, do you plan, like you're saying, do you plan to close up practice, then there's questions why, and do you plan to leave Florida, yes or no, and if yes, where do you plan to go? And so we have all that data, and we have it by county, and so that's a really good thing that Florida started doing that. And so we're now, 7 years into it, and we're just beginning to see some trends. So it's really, really good. And what we tried to do is tie in the HPSA information with it too, so that we can see where the really high needy areas are and how that relates to the shortages and intentions of physicians for the future of their practices. So all of this is really important when we think about even just pieces of the Affordable Care Act that have to do with expanding access to care. So I think we're well prepared in that sense, the state is, with this physician workforce report. And we also, part of that program is there's a physician workforce advisory council, which is made up of deans from the schools of the colleges of medicine here in Florida, representatives from the hospital association. So it's a group of physicians plus stakeholders, and we have quarterly calls, and lately we've been having weekly calls because of there's been legislation proposed by the governor for providing $80 million to hospitals that are Medicaid hospitals, but also have graduate medical education programs. So we've been kind of monitoring the legislation, and the Physicians Workforce Council decided they wanted to have conference calls every week to, stay on top of it and make sure that if it passes, it goes through, that it doesn't miss any key points. So, and we have a strategic plan for improving the physician workforce shortage problem in Florida as well, and that's part of the report that's on our website. But I'd say overall in Lake County, I think it's just a really good thing that you have all these Conrad 30 doctors, and that whatever it is that attracts them here, it's a good thing. So, maybe that's something as a group you can all figure out. It's hard to keep doctors. And one thing I learned yesterday from the group of them, and I was really kind of taken back by it, there's always talk about, well, doctors don't want to go to rural areas, and they don't want to go to certain places because they want the schools to be good for their children, and they want, they don't want to be, they want to be in nice places, whatever a nice place is. But several of them told me yesterday that when they were looking at the map of where the physicians are, they said, it's not so much about schools or, you can live on the coast and go fishing or whatever you want to do. They said the reason why they all wanted to come to Florida, or they also applied to Texas and California if they can, is because they don't want to go to the other states where there's not very much population. Because they said if there's not enough population, then we don't have the big bulk of patients to work on and to keep our skills up and to keep our minds going. They love, like they said at Shands, they just love the practice challenges that they get there. And they don't want to go to, like, Minnesota or Nevada or, someplace that has a lot less dense population. I just thought that was really interesting, that it's always assumed they don't want to go places because of the schools or because of it's too isolated, but they were all saying it's all about their career and about having a good patient load to practice on. So that was good. So whatever it is that's here, they like it. So that's a good thing. Does anybody have any questions? Okay.
Thank you very much.
Thank you.
Would you please, we're technically a little bit over, we're now into the networking thing, so if there's any follow-up questions you might have regarding the workforce or the number of uninsured, we'll be mingling around. We'll be more than happy to kind of address them. But again, remember, the PowerPoint pretty much covers it all. And again, we wanted you to have something that you could take away, because that's most important. We would ask you another thing very important. Could you please fill out the evaluations? And they're just a little, there should be a single sheet, and there's only three little lists that you have to do. That's the kind of feedback we need to know whether something like this is something that we should try to provide in the future, or if in fact this is the kind of venue that provides you the information that you need. So please fill it out, and we're basically now in the networking stage. And for those of you who are not on a diet, after Donna gives us her kind of closure, we will go from there.
Yes. Basically, this reception is a farewell from the Florida Department of Health in Lake County to Wally. As Wally did retire from the state, his last employment area was with Lake. As you can tell, we were very fortunate. You heard me give his bio, but Wally, I do have a certificate for you for your appreciation here at Lake County. And also, you were one of the recipients, along with Ellen and Viviana, on a Davis Productivity Award that we won on clinic, the clinic management, clinic flow, break-even program that you all developed, and your letter is here from the Davis Productivity Award. Thank you, Wally, for everything you did.